Good afternoon. My name is Dr. Sai, and today this is our Wellness and Health lecture series scheduled for Dr. Ranawat, a very famous orthopedic surgeon. It gives me great pleasure to introduce Dr. Amar Ranawat, who specializes in hip and knee joint surgery. Dr. Amar Ranawat specializes in total hip and total knee replacement, revision, total hip and total knee replacement, and periprosthetic fractures. Dr. Ranawat is an active clinical orthopedic researcher and particular interest in alternative bearing surfaces for total hip replacement and rotating platform total knee designs. I'm pretty sure during his speech, he will explain what these technical terms mean. A leading surgeon in the field of orthopedics, he has focused much of his practice on hip and knee replacement, researching major advancements in technique and technology. I am sure very few orthopedic surgeons perform these complex procedures. He's a New Yorker all the way. He was born in New York City. He received his medical degree from Weill Cornell Medical College in 1996 before completing an internship at the New York Hospital and a residency at Hospital for Special Surgery. In 2002, he completed his fellowship training in adult reconstruction under the direction of his father, Dr. Chittaranjan S. Ranawat. Dr. Chittaranjan Singh Ranawat is an American orthopedic surgeon of Indian origin. I must take a couple of seconds to really talk about this famous surgeon. Dr. Chittaranjan Ranawat and Albert Burstein of the Hospital for Special Surgery, also in New York City, invented a hip replacement implant marketed by Biomed. In 1996, Dr. Chittaranjan S. Ranawat founded the Ranawat Foundation, a philanthropic organization, and in 2001, he received the Padma Bhushan, the third highest Indian civilian award. Each year at its annual meeting, the Knee Society presents the Chittaranjan S. Ranawat MD Award and two other awards for the best research papers that year. That was about his venerable father and an accomplished orthopedic surgeon. We feel so proud of him. Dr. Amar Ranawat has received numerous academic and professional accolades, including the Chief Resident Special Award, the Navy and Marine Corps Achievement Medal, the Hip Society British Traveling Fellowship, and the James A. Rand Award. Other awards include Castle Connolly Top Doctors, Castle Connolly Regional Top Doctors from 2013 to 2020, New York Magazine Top Doctors 2021, the Navy Marine Corps Achievement Medal, Emergency Limb Saving Surgery on a Marine 2007. The 2004 James A. Rand Award for the most outstanding paper in knee surgery, presented at the annual meeting of the American Association of Hip and Knee Surgeons, November 2004. He's the member of Eastern Orthopedic Association, International Society for Technology and Arthroplasty, American Medical Association, Medical Strollers of New York, U.S. Military, Lieutenant Commander, Medical Corps, United States Navy 2002 to present. Dr. Amar Ranawat is actively involved in clinical orthopedic research. He has presented numerous times on both the national and international level. His current interests include alternative bearings in the hip and rotating platform technology in the knee. Without further delay, Dr. Amar Ranawat will present this interesting lecture about the knee and hip joints.
Well, thank you for the kind introduction. It's wonderful to be part of this. As mentioned, I am a New Yorker, but I'm half Indian, and we go back to India every year, sometimes 4 times a year. Obviously, not as much in the last year, just from the pandemic that we're all having to deal with. But we have a meeting in India where we trained knee surgeons for the last 20 years, and my father started it, and we continue to run it. My brother and I. So we're very proud of our endeavors in training Indian surgeons in the best practices and techniques that are available. So today I'm going to share my screen. And I'm going to talk to you about just some common problems about the knee and common causes of knee pain. So these are my credentials. These are my financial disclosures. As doctors, we often work with companies to design products and to improve upon products. And so we are obliged to disclose those. As far as today's presentation is concerned, there are no financial conflicts. So let's start off with the causes of knee pain before surgery. You can have an intra-articular process, meaning inside of the knee, such as a meniscal tear or a ligamentous injury. We generally refer to this as internal derangement. And this can usually be dealt with non-operatively with injections or occasionally with arthroscopic surgery. Other very common causes of pain are bursitis, tendinitis, patellar malalignment, and then ultimately cartilage loss due to osteoarthritis. There are other conditions that can damage your cartilage in the inflammatory department, like rheumatoid arthritis, lupus, gout. You can always get an infection, which is one of the worst things that can happen. You can have a tumor, either benign or malignant. And very often, surprisingly, pain that we think is in the knee is referred from either the hip or the spine. So here's just an example of what a meniscal tear looks like. The normal pristine white cartilage gets a tear and a flap, which can get caught in the joint. And those can often, as I said, if they're mechanically obstructive, be removed arthroscopically. In younger people, they can sometimes be repaired, although the blood supply to the meniscus is not great. So more often than not, we tend to trim off the loose parts. And then major ligament reconstructions can be done of all the four major ligaments in the knee, which you see here, which would be the anterior cruciate, posterior cruciate, and then the medial and lateral collateral ligaments. Bursitis is very common. All around our knee, there are little pockets and pillows that are designed to cushion and protect the knee. If those become inflamed, they will swell up even more and then, in fact, cause more pain than protection. Usually, anti-inflammatories and rest and the concept of rest, ice, compression, elevation will do the trick, and it will settle down on its own. Occasionally, they need to be surgically removed, but that's very uncommon. Some people are born with conditions called dysplasia. It basically means your bones weren't put together properly. Usually it's a function of how you were born and different conditions of that nature. It's much more common in the hips than in the knee, but it can still happen in the knee, and it usually affects how your kneecap or your patella tracks in the knee. So if you have a chronically dislocating kneecap, that is a cause for knee pain and often will need surgery to correct. Perhaps the biggest diagnosis that affects most people after the age of 60 is osteoarthritis. That is the condition where the cartilage on the ends of the knee become damaged to the point where at first it thins out, and then ultimately it completely erodes away, and then you'll have exposed bone. And then if it happens on both sides of the joint, you will have the typical bone-on-bone arthritis. And that is usually when people have enough symptoms and pain where they will seek surgical intervention. In the beginning, anti-inflammatories, injections, physical therapy can all be somewhat helpful, but ultimately when it becomes a bone-on-bone situation, surgery and total knee replacement is the only answer. So I'm going to stop the show for a second and play this video, which is not playing in the program. So here you'll see the knee bending back and forth, and we're going to slowly remove the layers. So we've removed the skin and fat that's underneath or on the outer surface. Then we have the muscles, tendons, and ligaments. And now we just see the bone and the pristine cartilage on the end of the bone. And that's what is replaced with the metal and plastic in a knee replacement. So just to give you an understanding, we don't remove your whole knee. We just recover the ends of the bone. And we've done a lot of science and a lot of research in trying to make the mechanical parts function as well as the God-given parts. It's not perfect, but it's certainly getting very, very close to perfect. Whereas nowadays, most people in their 60s who get a knee replacement will not need to get another operation on their knee. I talked about sometimes the pain does not emanate from the knee. Sometimes it comes from your hips. You can have bad arthritis or dysplasia in your hips. You can have a slipped disc in your spine. These are all things that can refer pain, and the brain becomes convinced that the problem is in the knee, but it's actually being referred from somewhere else. So this is our job as doctors and orthopedic surgeons is to definitively diagnose where the pain is coming from. Now I'm going to switch gears a little bit and talk about what are the causes of knee pain after knee replacement surgery. So everything I talked about before was what brings you to see the doctor initially. Now we've diagnosed usually osteoarthritis, you've gotten a knee replacement, and you still have pain, or pain has developed after your knee replacement, and you want to understand why. The first and most common reasoning is wear and ultimately loosening of the parts. We usually cement the parts to the bone, although more recently we've used biological fixation to do that. And that bond can break down over time. Infection is probably the one diagnosis that we fear the most because it can cause multiple surgeries, and it can happen early on after the surgery, and it can happen later on after the surgery. And it's more often than not curable, but it can take months and months for that cure to occur. Fractures can always occur either in and around the surgery or later if someone were to fall, and that can often require surgery. Instability, that is a sensation of the knee giving way. It could be because the quadriceps muscle is not strong enough. It could be because the actual implants and the stability of the knee is insufficient to bear one's weight. So those are all issues that we have to diagnose post-operatively. Sometimes a knee is stiff and it won't bend the way we like, and it causes pain, and that can be a problem. And then, quite frankly, there are certain situations in which we don't have a good reason to explain why the knee hurts as much as they do. There are different conditions like regional pain syndrome and RSD, where some people just have a very difficult time managing and controlling their pain. So here's an example of a knee that's worn out. The bone is starting to get soft. There's lucent lines in the bone, and the bone gives way and fractures occur and the parts become loose. This will require a revision. Fortunately, this happens much more infrequently nowadays, or much less frequently nowadays. And this is more a problem that happened 20 years ago. As I said before, infection is always a concern. You can have wound healing problems. You can have all sorts of types of infections with different bacteria. Some are worse than others. The antibiotic resistant ones nowadays are the ones that are the most concerning. As I said, orthopedics and fracture goes hand in hand. So you always have to be aware of the possibility. Sometimes it can happen because you obviously fall and have a trauma, but more often than not, in the elderly, as your bone gets softer, you get osteoporosis. The bones can occasionally spontaneously fracture, and that has become a growing problem. And fractures can be small, minor, that just need limited weight bearing and soft braces, or they can be like this, where they're displaced and require major reconstructive surgery. Here's what instability is, where the knee, if you pull on it, it will move in a pathologic manner. The ligaments have given way. They can spontaneously rupture. They can slowly rupture over time and give way, stretch out. But if the knee is not stable, it can literally dislocate. And once again, these become surgical problems that need correcting. Stiffness is always a problem. It can happen early on. Occasionally, early after surgery, we will do what's called a manipulation, where we will bend your knee under anesthesia. But if the range of motion is not improving, it can sometimes require an open procedure. The first thing to recognize when we deal with stiffness, though, is that pre-op motion predicts post-operative motion. So if you come in with a very stiff knee, it is likely you will have a stiff knee post-operatively. And that's one of the reasons why we tell people not to delay their knee replacement surgery, because once you start to lose motion, it makes it much more difficult to return it. But there are lots of reasons for stiffness. Sometimes there's a mechanical block inside the knee, which can be cut out, and then the motion is restored. Other times, all the soft tissues around the knee become thickened and fibrosed, and that prevents the knee from bending. As I mentioned before, it's often related to poor pain control, and it'll sometimes require manipulations and occasionally revision surgery. And this is the one diagnosis that really bothers us, and this is why we still go to meetings and discuss. We can't always find a good explanation for knee pain, and the parts look well fixed. They're in good alignment. The knee is stable. There's no swelling. We looked in the hips. We looked in the spine. We looked for all intrinsic and extrinsic factors. We ruled out infection, and we still can't find a reason. So this is troubling. This is why many patients come to the hospital for special surgery, to try to see if we can shed some light on these very challenging situations. Occasionally it's technique related. Occasionally it's implant related. Occasionally it's because of postoperative pain management wasn't optimal. Sometimes some patients, they just have a bad reaction. They can have a bad reaction to the metal. They can have a bad reaction to the plastic, to the cement. So, the allergy question is one that's still plaguing us. We don't have an excellent answer. We put these parts into millions of people every year, and very, very few have these types of responses. So we don't think it's a major explanation, but occasionally it is. There's a lot of talk nowadays about using computers and navigation to do your surgery. I'll try to show this video again because I don't think it's going to play in the. Hopefully you can see that. So this is a sense of what computers, navigation, and robots can do. We put pins in the bone. It lets the computer know where the bone is in space. Then we can put our cutting devices onto the bone. There's no question this makes for more precise cutting of the bone and a more precise operation. However, the data in long-term studies, more than 10 years, have not shown any benefit than to a well-done knee done by a good surgeon. So I'll just briefly go over, what are some common mistakes that occur from the surgical point of view. This is something that happens extremely rarely at the hospital for special surgery, but poor exposure, not being able to see the bone well enough. That's the beginning of our training here. Everyone learns how to become excellent at exposing the hip and the knee. Inadequate balancing of the soft tissues. This is an operation that you have to respect the skin, the muscles, the tendons, and the ligaments. You can get the wrong size of the components, just like you can wear clothes that are the wrong size or shoes that are the wrong size. If you walk in a shoe that's the wrong size, you will know very shortly that you've made a mistake. Poor patellofemoral tracking, poor cement technique, improper closure of the wounds, and inadequate pain control. These are all the things we've identified and all the things that we teach on a regular basis to make sure that the knee replacements come out well. And as I said before, these are the main problems that are the reasons why some knees will need to have revision surgery. You can get an infection, you can get wound complications, hemorrhage or bleeding inside the knee, stiffness, persistent knee pain, a kneecap that does not track well, malalignment, instability, fixation failure, and then long-term wearing out of the parts and bone softening. So in conclusion, there are many causes of knee pain, both before and after surgery. For arthritis that affects all three compartments of your knee, the surgical treatment of choice is without question total knee replacement. There is partial knee replacement. There is kneecap replacement. But the most studied and the best evidence and data that exists today is for total knee replacement. It is without question one of the best operations of the last 50 years with regards to eliminating pain and restoring function. And I thank you very much. Here's a picture of the Hospital for Special Surgery on the East River. And there's my contact information. And I am happy to take any questions. Thank you.
Go with the questions. I just want to make a comment. Very few orthopedic surgeons have reached the pinnacle of their practice as the Ranawat family has. I know your brother, your dad. I mean, you know, some of the Indian kids, they don't want to go into the medical field. That's the trend. But, you know, just to ask you to begin with, what made you follow your father's footsteps?
I get that question all the time. And it certainly was not a decision that I made early on. I was about to graduate college when I decided I'm not going to go into banking. I'm not going to go into finance. And then I started the process of taking biology and chemistry and all the pre-medical sciences. So much, I started so late, in fact, that I graduated college, left college, and took the remainder courses back in New York City at Columbia. The point that you alluded to is that it is a long process. You know, it takes years to prepare to get to medical school. It takes 4 years to do medical school, 5 years to do residency, another year of training, and probably 5 years in practice before you become the beginning of something that can grow. And it's not for everyone. I agree with that. But at the same time, nothing in life that has value comes easily. You have to put your time and your effort and your energy in. And then when you do that, the rewards that it pays are endless.
Thank you, Dr. Ranawat. So we'll start with the questions. I think some of them are repetitious, but stop me or interrupt me if you can. The most pressing question for everybody, I think you touched upon it during the lecture. What is the appropriate timing for surgery? I know people have different etiology for their knee pain, and they come from different groups like age groups and stuff, injuries, etc., infection, especially for osteoarthritis, degenerative changes. And then it starts off now, I have noticed. I don't know if this has something to do with the jogging craze that we had in the 90s. Everybody has gone for knee replacement starting at the age of 50 or 60. So, what is the appropriate timing of TKR, if I may ask you? And of course, we'll get to the next question, which is the longevity of the equipment, of the processes.
Sure. So I'll try to shed light on a few very interesting facts. One, it is very unlikely that running or activity caused the disease. The disease is most likely genetically transferred, but it's not transferred always from parents to children. There could be generational gaps in that. Interestingly, people of South Asian origin will tend to have a much higher rate of knee osteoarthritis than other populations. However, they also will have a much lower rate of hip osteoarthritis than other populations. So clearly there's some genetic components to all of this that we have not fully, elucidated. But it's the answer to one of the questions is, it's not the running. It's probably your parents or your grandparents. And then number two, I think the question of when is the right time to do it. The right time to do it for the average person is to choose the right time on their second knee. Everybody on their first knee waits too long. And that's a very common theme. They will say, literally, I waited too long, because that's how good the outcomes are. But it's human nature. It's human nature to delay. Nobody wants to have this surgery. Nobody wants to go through the recovery. But the second time around, the minute the knee starts talking to them just a little bit, they schedule the surgery, right? So it's everyone gets surgery too late, but it's human nature. It's just the family knows, your spouse knows, everyone knows you need to get this done, and the last person to make that realization is the patient.
So do you think it's advances in technology that people are going early on for surgery, and before we used to see in the late 70s, 80s? And that would be the question. And you did say that the first one is always you take your time. Now, you also said waiting may have an impact on the post-op results. Am I correct?
Yes.
Could you shed some light on that?
If you start to become stiff, meaning you can't make your knee all the way straight, or you start to lose your bending ability, that can have an outcome, or that can have an effect on your range of motion post-operatively. But again, most people don't look at range of motion and get concerned. For them, it's a function of pain. So when the pain gets so bad, that's when they choose to get it done.
So the next question would be, what can you comment on the stem therapy? Is this something that you would really advise as a stopgap, or it's not useful at all?
It really is. There's very little data to support using stem cells. It sounds good in theory. In practice and in studies, it has not borne out. It is not FDA approved. It is not covered by insurance. For those reasons, I don't recommend it. Quite frankly, none of the data on any injection is very good. But at least with the cortisone shots and the gel shots, there is very little harm that has been documented, and it is covered by insurance. So there's very little out-of-pocket expense. Stem cells can cost upwards of $500 to $1,000 with very little evidence to support it being that good. So I would not recommend it.
So you're mentioning about the gel now. Everybody says, okay, you get the 3 injections, insurance covers it. It'll give you time up to 6 months. Is that correct?
So all these non-operative treatments have some benefit early on in in the disease process. So if you have mild to moderate arthritis in your knee, it can be somewhat helpful. Now, the reality is when you have mild to moderate arthritis, your symptoms are also variable. They'll come and they'll go. You'll have good days and bad days. So what we don't know is, did that injection actually help you, or were you going to get better that week anyway? Right? We don't know that.
Yeah.
We don't know that. But, there's no question the problem is when you get to bone-on-bone arthritis, severe arthritis, and then people keep trying to do injections to prolong their surgery. That's not helpful. And in fact, we do know now that there is an association between injections and infection. And we won't operate on anyone that's had an injection within 3 months.
Wow. That's interesting. Because, patients, I tell you, they want anything but surgery and just keep on postponing, like you said, the first surgery. And it seems after the fact, then it becomes very useful. And they have no pain. They may have stiffness, but the pain is gone. So that was very important. That gel injection, I think everybody asked. And I just want to also ask about the ACL tears and those kind of things that you do arthroscopically. Do you think that may hurt you or benefit you to defer the surgery?
So that's a very interesting question. There's no question that if you operate on a knee for any reason before knee replacement, it can lead to arthritis in the knee. Now, if you're 20 years old and you rupture your ACL and your knee is unstable, it's probably a good idea to get your ACL fixed to have a stable knee for the next 20, 30, 40 years. But it does increase your risk of getting arthritis in that knee down the road. It goes both ways. Having a torn ACL increases your risk, just the injury itself, and then getting it fixed increases your risk. But yeah, so there are many mechanical problems like meniscal tears, ACL injuries, ligament injuries that generally speaking should be fixed in younger people to give them a stable knee. But yes, that does put them at an increased risk for what we call post-traumatic arthritis down the road.
Now, coming to the next question, yoga. We're all big in yoga. And if you've heard, you've been to India, you said, in Kerala, there are like umpteen clinics that do this oil massage for different joints, and people swear by it. What would your comment be on that? Of course, it depends on the stage of the arthritic process and all that. Understanding that, is there a place for these alternative treatments?
Well, so the first point you made, is the most important, right? It depends on the stage of if your knees look like this, no massage is going to help, right? On the other hand, no one should argue that massage doesn't feel good, right? Yes, it feels good. Everyone enjoys them. The question is something therapeutic happening once the hands come off? There's very little evidence to support a therapy from that. Does it feel good? Yes. Is it doing anything biological or from a physiological point of view? The answer to that is no. But there's nothing wrong with feeling better in the moment. I think that's so. I think if you talk about alternative things like massage, like acupuncture, meditation, all of those things, I think those are all helpful. If it makes you feel better in the moment, that's fine. But it's not gonna make your knees, when they're bent like this, it's not gonna make them straight like that, right?
Yeah.
So I think that's the take-home point.
So the next question would be about robots. I know a lot of surgical fields have robots now helping them out. You did say that it's better to do it surgically, with your hands, rather than the robot working on the knee, the bones. Just kind of, if you can enlighten us a little bit on the robotic surgery, does it have a place in TKR or hip replacements?
I would argue that it has a role. Right now, it represents probably 10% of knee replacements that are done. So it doesn't have a huge role. It's very expensive for the institutions to have these robots. and the precision where the precision is better, the question is it clinically relevant? And the evidence, long-term evidence, has not been able to demonstrate a benefit to that improved precision. So it's not a guarantee that you're going to have a good outcome. And you can cut the bones, perfectly, but if you don't handle the soft tissues well, and you don't close the soft tissues well, and you don't manage the patient's pain control, the knee is can still have a bad outcome. So there are many other factors other than how the bone is cut as to how to get a good outcome. And the two things we do know that matter the most are going to a high volume surgeon and going to a high volume hospital. So my hospital does more knee operations than any other hospital in the world on any given day. So that's good. And I'm not going to sit here and say I'm the only person at my hospital that can do knee surgery. No, we have 25 other surgeons that can do knee replacement surgery at a high volume, and any one of them could do an outstanding job. I think sometimes it's finding a personality match that fits. Sometimes it's actually literally an insurance match that fits. So there are many factors that come into play. But if you want to talk about places to go to get your surgery for knee replacement, there are very few places in the world that can offer more volume than we do.
Great. That's very interesting information. And also, I know I have had patients who had surgery and had infections. You've done the revision surgery. Do you want to just comment a little bit on the periprosthetic fractures and the revision surgery, if you may? And also the primary prevention of infection, we all understand. The secondary part becomes so complex. And I know your specialization is in that field. I've seen a lot of post-op revisions done by you. A couple of them were my patients, actually.
Yeah, I think the first thing to recognize is these are extremely uncommon problems, right? So 99% of people that get knee replacement surgery do absolutely fine. Some can have up to 85% can have some persistent pain and stiffness of a minor nature. But when we're talking about infection, we're talking about 1 in 4 or 500 fractures, same sort of situation. So these are very, very uncommon things. I don't want to scare people, off the bat. But we still have not eliminated the risk of infection. There are obviously conditions that make it much greater risk. Obesity, diabetes, for instance, are the major ones right now. And so we recognize that. We try to do certain things to optimize those patients, to minimize those risks. Right now, we won't operate on someone that has uncontrolled diabetes. So there are many preoperative patient factors that we're trying to control to reduce those risks.
And of course, this may be interesting, and a lot of people have asked you, how long do the latest model of the knee prostheses last?
So, I think that's the good news. 20 years ago, when I started, we would quote people 10 to 15 years. So that meant if you were 65, 70, it was a pretty good deal. But now we're quoting 20 to 30 years. It's extremely uncommon now for us to see knees fail from wear and tear. So I think if you're 60 years old, that's not a reason to delay. A 50-year-old, it's really not even still a reason to delay. The bigger issue for the 50-year-old and younger is that a 50-year-old wants a 30-year-old knee, and a 70-year-old wants a 50-year-old knee.
Yeah.
Right. The total knee replacement is not a 30-year-old knee. It's just not, right?
No.
So I think that's the problem. It's a functional issue for the 50-year-old, whereas a 70-year-old who just, they love it. Their pain's gone. They can walk. They can do all the things they want to do again.
So like the prosthetic cardiac valves, I wonder if you have also different sizes and stuff, and how do you measure them preoperatively, or there's one kind of thing, the small, the medium, and the large?
Yeah, so that was, again, 20 years ago, we had only a few sizes. Now we have greater than 10 sizes per systems. There are a variety of different design tweaks. Most of them haven't shown any advantage or disadvantage, but sizing is really no longer an issue. Fixation really is no longer an issue. And, quite frankly, the implants are no longer really an issue. People are always like, oh, I want this company's implant or that company's implant. The weak link is really the surgeon and the patient. So an obese patient with uncontrolled diabetes with an inexperienced surgeon, that's a greater chance for a bad outcome than an experienced surgeon with a healthy patient.
Thank you, Dr. Ranawat. At this juncture, I'd like to introduce Dr. Uma Mysurkar. Ravi, would you like to please bring Uma? With her leadership, she's our president of the Hindu Temple Society. Uma?
Namaste. Namaste, Dr. Ranawat.
Namaste.
Namaste. What a pleasure indeed. First, of course, my sincere appreciation of your gesture, of your goodwill, of your training, especially hailing from the family. We say there are certain things hail in the family. Your family seems to have mastered knee, and especially knee and the hip replacements. And I think we're very proud that you're one of the Indians, and you've contributed so much already at your young age to this complex matter. And many of us, including myself, always have this problem of knee pains, inevitably postpone, as you just mentioned, hoping that tomorrow will be better than today. But indeed, tomorrow is worse than today. But what to do? Time flies away and you get involved with so many things. But I suppose everybody has to look into it, and learning from the experience that you just narrated, it makes us think that, yes, we can have much better longevity if we were to take care of the parts, the God-given parts, which also age. So on behalf of the Hindu Temple Society of North America, my deepest appreciation and thanks for your precious time that you have given us. And I'm sure all the devotees who participated and learned and had questions were very much clarified, and would certainly look forward to making some decisions on what they should do for their own knee problems. Knee and the hip pains, and I think backaches, they're all interrelated in my opinion, because they seem to go along one with the other, and more so with the type of services that people do, the kind of jobs that people do, and all of these contribute to the exaggeration of the pain, the discomfort, and sometimes so bad that you almost feel that, well, I could just go and buy a knee from the market and bring it. It is as bad as that. So I think you've made it so clear that people can look forward to better days ahead. And one question that I think, as I did mention, what is the post-operative recovery period after a knee replacement, Dr. Ranawat?
Well, that's a great question, and I think that is what scares most people, because quite frankly, the surgery is about 1 hour. The risk of death, it's much riskier to get into a car and drive to the hospital than it is to have the surgery. Most people now spend a day in the hospital. So that's, none of these things are really that difficult to deal with. But the problem is I do the surgery and then you go home the next day, and then for the next month, you have no desire within yourself to want to leave your own house. You can walk, you can go to the bathroom on your own, you can go to the kitchen on your own, you're independent in your own home, but your internal desire to want to leave the house is very limited. And then slowly, over 3 to 4 weeks, you start to get that confidence again, right? Because you have to learn to trust your knee. The first couple of days, you don't trust it, right? You're on a cane, you're on some walking device, and then you slowly start to trust it again. And you're still in pain, but you're like, I can walk to the corner, I can walk to this temple, and then before you know it, 3 months go by, 6 months go by, and then you're like, oh, everything's gone.
Great. Thank you. Thank you so much for such a clarified answer. So we do appreciate that, and we look forward to having some frequent communications, maybe once in 6 months. Can we have?
Certainly.
I think, you see, all these kinds of educational lectures are extremely important for our population, and they can learn so much from this and make some decisions on their own what they want to do based on some of these. So with that, I sincerely wish you the very best and even more success in your careers, and and we are proud of you, your accomplishments, your whole family's accomplishment. And we thank you immensely. May God bless you. Thank you so much. Namaste.
Thank you.
Thank you, Dr. Ranawat.
Thank you all. It was wonderful. And like I said, you have my contact information. I'm happy to have you reach out anytime you want.
Sure.
So any simple advice, just a timely surgery, and you want us to be very aggressive with post-op recovery, I guess? Not to sit at home.
I think the final bit of advice I would give is there's a saying, an apple a day keeps the doctor away. And that is a bunch of baloney. But what is true is walk a mile a day, and that'll keep the doctor away. So it's good for your heart. It's good for your lungs. It's good for your body weight. It's good for everything. And the only way you can walk a mile a day is if you take care of your hips and knees.
Right.
Certainly, exercise is a very important part in every aspect of your health. So that makes a lot of sense. Regular walking on flat surface, you don't have to do a big gym type of thing.
Exactly. That's my point. Yeah.
That's right.
Yeah.
Right.
It's very. Just one other quick question, if I may, because we had 1 hour slot. So, why Indians have the knee pain more than the hip? Was there any kind of background?
Yeah, it's an observation. It's we don't know the reasons why. So we know in people of Northern European descent, they tend to get more hip arthritis than knee arthritis, and then it flips as you get into the southern parts of Asia. We just know other populations of the world they have higher risk for certain cancers, certain conditions, but yeah, it's extremely rare to find someone of South Asian origin that has primary hip arthritis.
Wow.
But the knee arthritis is
bad.
So I can't tell you why, but that observation is true.
Since you mentioned India, just another quick question. Would you advise both knees be done at the same time? Because that's a trend in India. They just want to get it over with, and then therapy is just 2 weeks and you're done. They don't think of the consequences.
So that's an excellent question, and there's multiple factors that are involved. There's medical, physical, there's financial. So there are a lot of factors that come into play. But briefly, it's always going to be safer to do one at a time. The risk for, you have a good leg to stand on, right? The risk of a blood transfusion is far less if you do one at a time. And so all in all, it's no question, it's safer. On the other hand, if you do both from a money point of view and a time point of view, it's more costly, no question. There are certain conditions, especially in India, where there's a lot of under treatment right now, that many people present with knees that look like this, right? So it's very difficult to make one knee straight and leave the other one so crooked.
Wow.
Whereas in the U.S., most people have this is what we call deformity. They have much less deformity in the U.S. because we've taken care of more people, and so it's much easier to do one at a time when the deformity is minor. But when the deformity is severe, you almost have to do both. Otherwise, it becomes functionally very difficult to walk with one straight leg and one crooked leg.
So it depends on the extent of the deformity that you would choose.
Deformity is a factor. The finances is a factor. But no question, one at a time is safer.
One at a time.
Yeah.
Dr. Amar, you have any other questions?
No, I think he answered all the queries. Thank you. Thank you so much. Thank you.
Thank you so much, Dr. Ranawat. It was a great pleasure,
Indeed.
And your presentation was very meaningful and informative and
Yeah, I'm
kind
sure
of, yeah.
everybody learned.
So we will invite you back and maybe with a different topic. I know you're the expert in knee, but another orthopedic issue, right?
It would be my pleasure.
Thank you.
Thank you so much, Dr.
All right. Thank you. Goodbye, all.
Bye.
Bye. Okay, so we end the